taking part in International Medical Congress of Silesia 2023. My name is Wiktoria Siwka, and I have an honor of moderating gynecology and obstetrics session. I would like to welcome the esteemed jury, President of the jury, Professor Krzysztof Nowosielski, and members of the jury, Dr. Tomasz Wikarek. We would like to explain to you the rules of this session. The order of the presentation will be the same as in the abstract book. The maximal time for presentation is 7 minutes. When time is up, I will get up and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on the conclusions and finish the presentation as soon as possible. All authors can participate in the discussion. Esteemed jury, I would like to kindly remind you, if you are the supervisor of the paper which is presented, you should not assess the work. In the case, please cross out the number of your card. Dear participants, I would like to remind that if your work is presented in English, the discussion also should be run in English. If the commission will ask a question in Polish, the authors of the work are obligated to answer in English. For presentation and discuss in English, we will grant an additional 20% of the points value. If the discussion is run in Polish, the additional point for speaking in English will be not counted. We will kindly ask the jury to assess scientific value, way of presenting, discussion on contribution. When the session ends, we kindly ask to give the cards back to the coordinator. Okay, to begin, I think we can start with the first presentation. I would like to ask to present the paper, Prevalence of STIs Among Pregnant Women in Peri-Urban Health Centers by Glory Esther Kaunda. She is with us online by a platform, Zoom platform. So, hello? Do we hear each other? Okay, maybe at the end of this session, we'll try again. So now I invite the author of the second work, Wiktorię Kępińską. She will present works under the title Opinion about Motherhood Among Polish Women with Turner Syndrome. The stage is yours.
Good morning, dear Commission, dear listeners. Today, I would like to give a presentation titled Opinion about Motherhood Among Polish Women with Turner Syndrome. Turner syndrome is a genetic condition caused by the complete or partial lack of one of the X chromosomes. It occurs in 1 in 2000 to 1 in 2500 live-born girls. To the characteristic picture of the disease belongs, among the others, short stature, lymphedema of the hands and feet in the neonatal period, congenital cardiovascular abnormalities, for example, aortic coarctation. Many dysmorphic features, such as low posterior hairline, webbed neck, or voluntary abdomen, but also primary or secondary amenorrhea due to primary ovarian insufficiency, with hypergonadotropic hypogonadism. What do we know about ovarian function and puberty in TS patients from the literature? Follicles disappear prematurely from 18 weeks of pregnancy onwards. However, more than 30% of girls present some symptoms of puberty in mosaic patients, even 50%. In 20%, we observe spontaneous menarche, and about 2 to 10% may achieve spontaneous pregnancy, and it's also more common in mosaic patients. The inability to have biological children is a leading problem among TS patients and their families. For this reason, a questionnaire was created to investigate opinions on motherhood among adult women with TS and to determine the need for research to preservation of ovarian tissues in teenage TS patients in order to use them for assisted reproductive techniques in adulthood. In the period from November to December 2022, adult Polish women with TS were contacted via the Messenger application. A 15-question original anonymous survey was conducted on women with Turner syndrome view on having children. Participation in the survey was voluntary and free of charge. The invitation to participate in the research was sent twice to 120 women. We received 58 responses. Now, I would like to present the results of the survey. Most of the respondents were from the age group from 25 to 34, over 40%. Definitely fewer answers in older age groups. 19 women answered that they had been diagnosed after 15 years of age. And another 22 cases in age group from 7 to 9 and from 10 to 15. The diagnosis was made prenatally in 2 cases. The dominant karyotype, 25 out of 58 responses among the examined women, was the classic 45X0. Over 1/4 of the respondents declared that they had menstruated spontaneously. Among women who received estrogen therapy, the age of starting therapy was most often defined between 17 and 18 years. But over 1/5 of respondents declared that they hadn't started estrogen therapy. About 65% of respondents declared their desire to have children. There have been 3 cases of spontaneous pregnancy. 24 out of 58 women declared that they had never discussed motherhood options with their physicians. 36 replied yes in answer to the question, if you had your ovarian tissues preserved in your childhood, would you like to use it for the pregnancy in the adult age? About 15% excluded this method as a way to get pregnant. Over 20% answered, I don't know. There were no cases of ovarian tissue preservation in the surveyed women. Over 2/3 of respondents declared awareness of the risk associated with pregnancy in women with Turner syndrome. To the question, do you have contraindications to the pregnancy? About 43 of women answered, I don't know. Contraindications were known in less than 1/5 of patients. Over 40% of TS patients declared that they received cardiologist care. The heart disease was diagnosed in about 33% of respondents. 2 women chose the answer, I don't know. 11 women answered that they suffered from an arterial hypertension. To sum up, most women with TS, given the opportunity to use oocytes saved in their childhood, would take advantage of this option. Further discussion of fertility preservation in patients with Turner syndrome is needed. The parties to the discussion should be the patient, regardless of the age, the parent, and the attending physician. Before making the decision to collect tissues, it is necessary to assess the risk of pregnancy and psychological assessment of the patient. Thank you.
Thank you for your presentation, and now it's time to discuss.
Thank you very much. That was a very nice presentation. This is a huge, I wouldn't say huge, but this is an important problem because those women are left alone and nobody cares about their reproductive health. Would you consider and changes in guidelines that would make it make it an option for them to consult with reproductive medicine specialist in case they want to be pregnant or want to have children?
It's a huge problem if the diagnosis is made in older age groups. For example, in my work was present that one of the women was diagnosed in 15 years of age and older. It's relatively older age groups for this procedure. For example, preservation of ovarian tissues, which should be made earlier if we would like to have better results and biological options for preservation. We know that if a patient is younger, we have more biological options for preservation. So yeah, I think time of diagnosis is very important in this problem.
Presentation was very interesting, and I would like to ask how you can find so many respondents to your work. How you find so many respondents to this topic?
I was participating. Okay. On Facebook, we have groups for women with Turner syndrome where we can contact via the messenger direct. I'm also a TS patient, so I'm member of this society in Facebook and down in Messenger.
One thing, last question. Would you consider, because ovarian tissue preservation, it's kind of new method, and the best way would be to stimulate ovaries and to preserve oocytes, but that's difficult in a way. So would you consider consulting women and encourage them to do that procedure, or rather encourage them for adoption?
I think if is the biological possibility, I think is a good option for these women for preservation. Yes, from psychological. I think it's also it could be possibly very hard if we can't have biological children, so it's probably better for psychological health also if we had options with preservation.
Thank you very much. Congratulations. Okay, it's time for third presentation. I invite Joanna Kazimierczak to present the paper, The Knowledge about Nutrition and Supplementation During Pregnancy Among Polish Women. Please feel free to start.
Good morning, ladies and gentlemen. I am Joanna Kazimierczak, and today I have the pleasure to tell you a little bit about the knowledge about nutrition and supplementation during pregnancy among Polish women. It's not working. Okay, thank you. The next slide, please. Okay. So for a very long time, there have been many myths about nutrition during pregnancy. But right now, it looks like women know much more about this topic, and that's why we decided to check the level of knowledge among Polish women. But before I move on to our results, let me quickly remind you the basic rules of healthy nutrition in pregnancy. In fact, it's not much different from rules that we lead in a healthy lifestyle of our everyday life. What is really important for future mothers is to quit alcohol and cigarettes, as they may lead to many defects of fetus. I would also like to emphasize the importance of the proper supplementation recommended by the Polish Society of Gynecologists and Obstetricians. Okay, so we asked women about vitamin D, folic acid, and iodine. Why did we choose those elements? Well, vitamin D is really important for bone development. Every pregnant woman should take at least 400 to 600 units per day. Vitamin D also can be found in many products, for example, in fish, eggs, and cheese. Then we have folic acid. Folic acid helps to prevent defects of brain and spine. Every woman before pregnancy should start the supplementation of this element. Every woman of reproductive age should take 400 micrograms of folic acid every day. Folic acid can be also found in chickpeas, spinach, and parsley. Then we have iodine. Iodine is really important in prevention of brain damage. World Health Organization recommends the intake of 250 micrograms daily, but also iodine can be found in fish. Healthy lifestyle gains more and more popularity every day. It's really easy to obtain pieces of information in social media or TV programs. Women also try to change their nutrition habits during pregnancy to help their fetus to grow and develop properly. Bearing that in mind, the point of our research was to check the level of knowledge during pregnancy, about nutrition during pregnancy among Polish women. We used the online questionnaire, which was distributed to 173 women in February and March 2023. The obtained results were statistically analyzed by using the program Statistica 13. The inclusion criteria were sex, because the survey was only for women, and those women had to be pregnant at least once. The survey contained questions about basic demographic data, questions about nutrition and supplementation, as well as the test checking the knowledge about the main talking point. Our group was divided into 5 age groups, and more than 50% of them were women over 30 years old. And moving on to the results, the younger respondents achieved better test results than the older ones. If it comes to sources, women got their knowledge from many variable sources. They mostly chose internet, their own beliefs, and the other women's knowledge. What is interesting, but I would say also shocking, only 7% of women chose antenatal classes and 10% chose gynecologists as their sources of information. Women who attended antenatal classes were more likely to supplement vitamin D. Also, women who had a conversation with their doctors were more keen to supplement this element. The older the responders, the less likely they supplemented vitamin D. Education may have an impact on supplementation of vitamin D, as women who gained a higher level of education were more keen to supplement vitamin D. What is really surprising, the number of pregnancies also had a significant impact on the supplementation of vitamin D. Women who were pregnant more than once did it less often, while those women who were pregnant only once did it more often. If it comes to iodine supplementation, The older the responders, the less willingness of supplementation of iodine. Also, women who declared to not attend antenatal classes were more unlikely supplemented vitamin D. Sorry, iodine. Okay, and moving to conclusions, there is a need for a better education regarding nutrition and supplementation during women, because education may have an impact on the knowledge of the women, as women who gained a high level of education are more conscious of the problem of nutrition and supplementation during pregnancy, but also probably can choose the most reliable sources of information. We would like to encourage gynecologists and obstetricians to start conversation with their patients as soon as it's possible, so optimally before pregnancy. Thank you for your attention, and if you have any questions, feel free to ask.
Thank you very much for a good presentation. Any questions?
Very nice presentation, thank you.
Thank you.
This is an important subject, as nutrition during pregnancy and before pregnancy can influence the pregnancy outcomes. The question is, because there were really nice results, and there were some dependencies, as older age decreased the likelihood of taking supplements. Can you find any reason why? And the women that were in next pregnancies, so the more pregnancies, the less likely the likelihood of supplementation is lower. Can you explain, maybe do you have any ideas why?
In my opinion, it depends on the age, because women who are older, let's say maybe they are less interested in supplementation, they don't know how to find the reliable sources of information. They believe that they know what's the best for them and for their child. They listen to other women in their age, while younger women search for the answers. They search for new informations. So
yes, again, that's what I thought. Maybe it would be a good idea to check the correlation between the age and going and source of knowledge, or talking with gynae obstetrician about the supplementation, because I guess that the correlation would be positive. So the younger woman would go for online searching and trust online resources more than the older one. Older trust gynaes, and gynaes are not willing to cooperate or to talk about the supplementation. Really nice work. I think you should go further and explain more details. Just go deeper and deeper.
Okay, thank you.
I haven't got the question because I never work tutors.
Okay, so thank you so much once again.
Thank you and congratulations. And now it's time to fourth presentation. The title is The Issue of Dysmenorrhea Among Young Women in Poland by Piotrowska Karolina.
Good morning, ladies and gentlemen. My name is Karolina Piskorowska, and I am very happy to have an opportunity to present our work. The title of our paper is The Issue of Dysmenorrhea Among Young Women in Poland. The plan of our presentation is as follows. You can just read it. At the beginning, I would like to emphasize how the problem of painful menstruation is downplayed in Poland, even by the affected women themselves, as well as by doctors. On the slide, we can see just a few of many comments that respondents posted under our survey. I will cite a few of them. Such is your nature, taught by a doctor. I often have to use a mixture of painkillers to relieve pain. Several gynecologists refused to diagnose, and the only suggestion was contraception. It indicates with what helplessness women have to face. What is dysmenorrhea, you may ask? By definition, is the presence of painful cramps of uterine origin that occur during menstruation and represents one of the most common causes of pelvic pain and menstrual disorder. According to the World Health Organization, it affects 17 to 83% of young women. There are several factors that can lead to the painful menstruation, for example, young age, family history of dysmenorrhea, and early age of menarche. Our study was conducted via internet poll. Participants had to respond 36 questions. Data was collected during the first quarter of 2023, and the anaerase and MDQ-SK were used in the form. MDQ-SK is verbal multidimensional 4-point scale to assess the severity of dysmenorrhea. It categorized painful menstruation into 4 grades, such grade 0, which means no pain, grade 1, it's mild pain, grade 2, it's moderate painful menstruation, and 3, it's severe pain. 78% of women who participate in our study suffer from pain during menstruation. Furthermore, almost 60% of them rate the pain at least 8 in the anaerase scale. 98% of women who require medication to relieve pain. What is interesting, 75.6% of them use non-pharmacological methods of pain management. But only 33% of women who declared that the pain reduced the quality of life had asked a specialist for help. Most women ask why they did not go to the doctor. They respond that they could handle it themselves or got used to the pain. For generation, the disregard for the problem of dysmenorrhea by women and by doctors has led to the opinion in society that menstruation must hurt. Women are convinced that they live alone and seek their own solutions. Only appropriate treatment significantly elevates the symptoms. One of the options of treatment of dysmenorrhea is hormonal contraception. Our study showed that the women who use it were significantly less likely to suffer from pain, which was statistically significant. Pregnancy has also been proven to have a positive effect on dysmenorrhea, which was also confirmed in our study. We do not find association between dysmenorrhea and vitamin D supplementation, smoking, physical activity, BMI, length of bleeding, or age of menarche. As a matter of fact, just 31.9% of women who sought a medical attention received help. What is even more devastating, just 21.6% of them actually found the case of their pain. Okay, but you may still think that it's just stomachache that any woman can experience, survive, and move on. The question is whether it's so harmless to have for sure. As you can see, we find some researches that indicate that dysmenorrhea may increase the risk of stroke and ischemic heart disease. This shows that this condition is not only affected the quality of life, but can also lead to the other serious life-threatening disease. So what we can do? Despite its high prevalence, dysmenorrhea is often underdiagnosed, inadequately treated, and normalized even by patients themselves who may accept the symptoms as an inevitable response to menstruation. Women should more often see the doctors because dysmenorrhea may be caused by serious disease. Treatment should be carried out by testing methods with proven efficacy, such as non-steroidal anti-inflammatory drugs and hormonal contraception. We should raise awareness among Polish society about this gynecological disorder, especially doctors, to avoid disregarding and undiagnosis. Thank you so much for your attention, and if you have any question, of course, please ask. I will be happy to answer it.
Thank you very much. Good job.
Thank you very much. Very nice presentation. Few things. There's a huge number of women with dysmenorrhea. It's almost more than 80%. How did you approach the woman in this study? Well, you said that via internet, but did you post the advertisement or send emails?
We posted our survey in some Facebook groups or sent to our friends and so on.
When you doing such a study, collecting the samples, collecting the questions, and choosing the right population to send the question might be very important because of the bias. It's really high. The WHO says 17 to 80%,
Yes.
and you have almost 80-something%. That's huge. So we have to be very careful about that. The other thing is, you said non-medical, non-pharmaceutic method of dealing with pain. What do you mean by that?
I mean about this, for example, yoga, it was physiotherapy, some others.
Some physical activation and activity, and that's
maybe diet, because it's
yes.
we are talking a lot about microbiota. So there are many papers about the physical states and health of women with dysmenorrhea and microbiota. And the last question, do you consider analyzing the correlation between other factors like BMI, age, pregnancies, and the frequency of dysmenorrhea?
Yes, but anything wasn't statistically significant.
The same question, because I would like to ask, do you know the main age of this woman which you examined? Because it's quite interesting why so many women have got pain during this month.
About 28 years.
So quite young.
When we're talking about stroke and dysmenorrhea, what was the mean age of that population? Because there must be other factors correlated with heart attack and dysmenorrhea.
Good. The main age was a woman younger than 30 years old.
Okay, and thank you very much. And I just want to wonder that all of you can ask a question for our participants. So if you want, just take a hand and I. Yes. Okay, so now I would like to ask to present the fifth paper by Marcin Goławski. He will present the paper about the causal link breastfeeding and intelligence in non-trivial and Mendelian
randomization.
Okay.
A difficult word, but don't worry, I'll explain it. Okay, so good morning. My name is Marcin Goławski. I represent the Department of Pharmacology, Faculty of Medical Sciences in Zabrze, Medical University of Silesia. And today I would like to present the results of our Mendelian randomization study regarding the causal link between breastfeeding and intelligence. How do you change? Okay. Okay, so now on to the introduction. So it is well known that breastfeeding is correlated with positive health outcomes. Nevertheless, such correlations coming from and data for odds ratio of being breastfed was collected from Pan-UK Biobank. And we only utilized variants that were at genome-wise statistical significance for the correlation of between for the intelligence, and which were not in a linkage disequilibrium, and that had no correlations with other factors like gynecological diseases, psychiatric disorders, or personality traits. Could you skip to the next one? Yeah, thank you. Now on to the results. So on these plots, each dot represents a variant. On the x-axis is the correlation with genetically determined intelligence. On the y-axis is the correlation with the odds ratio of being breastfed. As we can see, the variants that are likely to cause intelligence are also likely to be correlated with breastfeeding. Both inverse weight mean and MR-Edger methods indicate this. The difference is that in MR-Edger, the trend line does not have to go through the point 0. The correlations are very strong. Other methods yielded similar results, although this was not significant for mode, although the numerical result was the same. MR-Edger intercept tests did not indicate significant pleiotropic effects. There was some degree of heterogeneity between the variants, although this is to be expected in this type of studies, and leave 30% out analysis that do not indicate significant influence of single variants. Now on to the discussion. So obviously, the results from this study cannot be definitive and conclusive, but nevertheless, we assumed that there are more variants that influence intelligence, which is correlated with mother's intelligence, which in turn increases the odds of being breastfed, then there are variants that cause breastfeeding directly and influence intelligence through this mechanism only. Obviously, this is nothing conclusive, but the fact that the results are non-negative indicates that we cannot extrapolate the results from observational studies into clear and definitive conclusions as to what the correlation between breastfeeding and intelligence is. Thank you very much for your attention.
Thank you very much for the presentation. It was a science fiction for me a little bit, especially as far for the statistic analysis. Anyway, I'm not a specialist in intelligence, but how is it inherited? You said that the mother's intelligence, would you consider check for father's intelligence? Because I think there are some cross correlation in that. That is the first question. Maybe there is a time to have a prospective trial to check that. That might be a good idea, to observe children when they are growing and check the intelligence early in the childhood and correlate it with the mother and father intelligence.
Okay, so I really like your question, because indeed the correlation with father's intelligence, this may also be a causal factor at play here. But nevertheless, if it is the father's intelligence that is causing the breastfeeding, then it will still have some kind of a problem in interpreting the observational result, because now the father is also a confounding factor. Well, as far as some kind of higher quality data, I think there was some kind of randomized trial regarding the breastfeeding, which also, I think, measured intelligence, and there was some kind of positive result, although this definitely shows that the observational studies and estimates from observational studies are definitely a subject of bias.
Thank you.
Thank you very much.
Any other question from you guys? No.
Should I specify my involvement in this work? I don't think it is. I don't know if this is the requirement or if it is rated.
We have time, so we
Okay, so my contribution to this work was conceptualization. I collected the publicly available data, selected the variants, and interpreted the results, and prepared this presentation while my tutor performed the analysis based on the player, and I prepared for some elements.
Yeah, the other one, the green one. Oh, yeah. Yes, confounding factors. Did you check for, like, how many confounding factors did you check for?
In reality, it is very difficult to exclude these confounding factors completely, and the specific checks are not usually typical for this method. I mean, there are more advanced ways to approach this, like multi-factor or perhaps network Mendelian randomization. But nevertheless, it is usually assumed that those confounding factors influence, their influence averages out between the variants, because the variants are randomly inherited and they are unchangeable. Each time a person is conceived, it's a total lottery. It is literal randomization, like in randomized trial, what the genetic traits will be.
Okay, time is up, so I need to thank you. Really good job. Okay, and now please welcome Zuzanna Tarkowska. She will present the paper about sexual dysfunction in women caused by pain during penetration.
Good morning, everyone. My name is Zuzanna Tarkowska. I would like to present to you sorry. I would like to present to you our presentation about dyspareunia, which affects women's sexual life. Next one, please. Yeah. Dyspareunia, briefly defined as painful sexual intercourse, negatively affects the psychological well-being and quality of life woman, and disrupts other domains of the woman's sexual response cycle. We can divide primary dyspareunia, which can exist in a woman's whole life, and secondary dyspareunia, which appears later as a result of certain events or disease factors. The pain can be caused by low vaginal lubrication. It also depends on the woman's emotional state, but also on her relationship with her partner. Pain can occur in a certain position, but also with a long break since the last intercourse. The study was performed using a proprietary questionnaire, which was a survey conducted anonymously. It included 50 single choice and multiple choice. The survey was conducted until 29 March to 10 April through internet forums and among friends. Only ladies who had been sexually active for the past 6 months, were not pregnant, and had not suffered from reproductive or urinary infection can, in the past 6 months, were qualified for our study. The purpose of our study was to find possible causes of pain during penetration. Our research involved 172 women between the age of 18 to 43. Where the largest number of respondents were in 18 to 22. The largest percent of women survived showed that they are ladies with a secondary education. However, in terms of the place of living of the respondents, the values were very close to each other. It should be noted that the subjects in our survey showed a stressful lifestyle, but most part of women find time to the rest. As for the sex life of our respondents, when asked the question when they did have their first intercourse, 146 women answered that the age of 18 to 22. They had the first intercourse, and 26 respondents answered that the age of 21 to 30. 72 respondents had intercourse with only one partner. 36 women had 2 partners, 32 women had 3 sexual partners, and 32 women had 4 or more sexual partners in their lives. More than half of the women answered that they are sexually active the least once a week, and 60.9% of women pleasure themselves by onanizing once a week. As for the contraception, almost 16% of women use condoms. Almost 30% use the contraceptive pill, and 10.2% declared that they do not use contraception. Now we would like to present our results. As you can see from the attached diagram, only almost 12% of women survive have never experienced pain during intercourse. The rest of the women have experienced the pain at a minimum once in their lives. It can be seen that this is a problem is quite popular in our environment. We can also note that this pain mainly appears after the first sexual contact, which means we are mainly dealing with secondary dyspareunia. Primary dyspareunia also occurs, but in a lower percentage. As for the location of the pain, 48% of the women could not identify the location of the pain, which showed a little knowledge of their bodies and the structure of the reproductive organs. The most common location of the pain was the vaginal fornix, 25%, which indicates deep dyspareunia, which can be associated with too deep penetration. Comparable results when it comes of pain in the vaginal vestibule, shallow dyspareunia, and generalized dyspareunia occurring throughout the vagina. In the chart, we can see that we have a comparable results regarding the timing of the pain. Pain most often appears at the beginning of intercourse, which may indicate low vaginal lubrication or not taking into account foreplay before intercourse. The second most common answer was pain appears at the beginning of intercourse and disappear after the intercourse. It's over, it can be influenced by deep penetration, bad position, and even the emotional state of the woman. Asking women in which position they felt discomfort, more than half selected the answered missionary position. Pain can occur during this position due to high pressure exerted on the front wall of the vagina. In the second place was the sitting position in which the penetration occurs. Vaginal lubrication. This is one of the reasons for the occurrence of pain. With low lubrication, there is a friction and abrasion in the vestibular area. 49% of respondents experience a problem with the vaginal lubrication from time to time. 13% have a constant problem, and 38% do not struggle with this problem. Sexual dysfunction can be both a symptom cause a complication of treatment or depressive disorders. For depressive disorders, sorry. The available literature describes the numerous connections and correlation exists between these disorders. Our subjects also suffered or still suffer from depression and struggle with the pain. We also see that it doesn't have 100% impact because large percentage encourage pain less than 5 times but never had depressive disorders. Just as we can see in that chart, a very important influence of pain during intercourse is self-esteem and the relationship with our partner. A healthy relationship, a healthy relationship that is built on correct foundation like trust, support, and understanding is the key to have an exciting sex life in our relation. To conclusion, dyspareunia, painful sexual intercourse with negatively affects a woman's psychological well-being, quality of life, relationship with our partner, and her own self-esteem. This disorder is constantly underreported by women, even though it's the primary reason for consultation with specialists. In the literature, most of the studies on dyspareunia are rather in the field of gynecology, while we think on the basis of our study that one of the primary causes of pain is depressive disorders, but also influenced by psychological aspects in relationship and low female esteem. Thank you very much.
Congratulations, and let's start to discuss.
Thank you very much for the presentation. Really nice work. This is a difficult topic because sexual dysfunction are common, but underdiagnosed, I would say, and there are strict criteria for diagnosing. So in this paper, I wouldn't say sexual dysfunction, because if you have strict criteria for sexual dysfunction based on DSM-5 diagnostic criteria. So in this case, there is a 6 years period when you feel the discomfort during sexual intercourse. But that's just a tip how to publicate the data. I wonder why you have how did you diagnose depressive syndrome? Because you said a lot of female in this study had depressive syndrome, and that might influence on the result. The other thing is the condoms. 60% are using condoms as contraceptive methods. Can you deliberate on that and explain why do you think it's happening? So the depressive symptom, why it's so high, and the condoms use.
So about condoms, I think that the woman doesn't take a contraceptive pill because they have a very ja mogę po polsku. Okej. To według mnie kobiety rezygnują z tabletek antykoncepcyjnych, ponieważ mają dużo skutków ubocznych i do tego też używając kondomów dochodzi też do jakby małego nawilżenia pochwy. Przez to też dochodzi do tego, że kobiety może przez to boleć i może dochodzić do tej, ponieważ w naszym badaniu też zadałyśmy pytanie na temat tego, czy używają lubrykantów, globulek dopochwowych. Większość kobiet nie używa tego i to się łączyło z tym, że te osoby, które używają prezerwatyw, nie używają też żadnych lubrykantów. I dochodzi też właśnie do tej suchości jednak otarć i to też przez to kobiety boli, ale jeżeli chodzi o depresję, no znalazłyśmy takie powiązanie, ponieważ większość kobiet w naszej ankiecie odpowiedziało, że jednak choruje albo chorowało kiedyś na tą depresję i pokrywało się to z tymi bólami podczas stosunku. Jak widać było nie w 100%, ponieważ osoby, które nie chorowały nigdy na depresję nie miały tego bólu, ale w większości tych korelacji pomiędzy też relacjami pomiędzy partnerem to bardzo wpływało i też samej oceny o sobie i jak się czuje sama w sobie to korelowało z tym bólem.
I jeszcze dam odpowiedź, dlaczego te kobiety używały prezerwatyw. Może być tkwić też w tym, że większość była bardzo młoda, bo tam większość tych pacjentek
tak, było
18-22 rok życia
tak.
i to też może być argument, dlaczego taka forma antykoncepcji, a nie inna.
Jeszcze jeżeli moglibyśmy zobaczyć taki wykres, bo jest ten more than 5 or less than 5. O co chodzi? Nie rozumiem tego. Yes, at every intercourse less than 5, more than 10, more than 5.
Te osoby, które na żółto mamy osoby, które miały depresję i to się pokrywa, że miały to jakby ból przy każdym stosunku, później mamy mniej niż 5 bóli, później mamy więcej niż 10 tych razy odczuwał ten ból i more than 5, więcej niż 5.
Tylko że generalnie jak potem patrzy się na te slajdy, to tak naprawdę nie za bardzo wiadomo o co chodzi, więc lepiej podzielić to taka wskazówka na przyszłość, bo praca jest naprawdę fajna, ciekawa. Trochę trzeba popracować byłoby nad tym, że nie do końca to są disorders, dlatego że mamy przyczynę, zaburzenie depresyjne, zupełnie inna grupa i trzeba to podciągnąć pod inny rodzaj zaburzeń, gdzie tkwi problem inny, psychologiczny czy psychiczny i generalnie to chyba byłoby problemem. Tutaj bym tylko na tym popracował. Ale ostatnie pytanie, bo nas goni czas. Jakie byłoby najprostsze rozwiązanie, jak panie myślą tutaj w tej grupie? Bo wydaje się, nasuwa się samo i panie o tym powiedziały. Nie było tych dolegliwości bólowych.
Żeby nie było dolegliwości bólowych, no to jakby zadbanie o własne tak jakby szczęście według mnie, znaczy to jest jakby, no mówiłam też o nawilżeniu pochwy, które jest dość ważne w tym przypadku.
Mówiła pani, że nie znają swojego własnego ciała.
To też jest prawda.
Edukacja seksualna tu jest kluczem, bo większość tych rzeczy, o których pani mówi, to jest kwestia edukacji, pomówienia, stosuj lubrykanty, zmień pozycję, pogadaj z partnerem, bądź szczęśliwa.
Tak, i stosują rozmowy pomiędzy partnerami, wynika to z złych tej jakby relacji w związkach, które są dość istotne.
Także to bym dodał i super praca.
Dziękuję.
A czy tam jeszcze był podział w zależności czy te pacjentki rodziły, nie rodziły i w jaki sposób rodziły? Czy to było też problem?
Był, ale nie dawał to korelacji, ponieważ nasza grupa wiekowa składała się głównie z młodych kobiet i większość tych kobiet nie rodziła. A jeżeli pytałyśmy o rodzaj rodzenia, no to były drogą cięcia cesarskiego i też z nacinami krocza i to się niejednoznacznie pokrywało z tym bólem.
Thank you very much for this interesting discussion. And now the next participant is with us on the Zoom platform. So Natalia Kwiatkowska, do you hear me?
Yes, I can hear you. Can you hear me?
Yes, and also
Perfect.
I can see you, so you can start.
Okay, so the most important question, can you see my presentation?
Not yet. Oh, okay. Yes.
Okay. Just 1 second, I'll try to... Okay. So, dear committee, dear colleagues, my name is Natalia Kwiatkowska. I'm 6th-year medical student from Poznań University of Medical Sciences. And today I'd like to present the results of our research, complete blood count parameters as a prognostic marker of cancer, ovarian cancer recurrence. And to start with my presentation, ovarian cancer is a critical public health issue that affects millions of women worldwide. It's the 5th leading cause of cancer-related deaths among women, and due to the non-specific symptoms and the lack of effective screening methods, it's often diagnosed at advanced stages. And as you can see here on this graph, factors such as age, family, and reproductive history can impact the individual risk of developing an ovarian cancer. And despite the advancements in treatment, the 5-year survival rate for advanced stage ovarian cancer patients remains low, emphasizing the need for improved detection and monitoring. And currently, as we all know, several biomarkers such as CA125 and HE4 are utilized to help diagnose and monitor ovarian cancer. However, these biomarkers have limitations such as low sensitivity and specificity. Therefore, there's an ongoing need to identify novel and more reliable biomarkers to improve ovarian cancer management. And that's why we aim to investigate the relationship between lymphocytes, neutrophils, and platelets levels in ovarian cancer patient before treatment and their time to progression. We collected data from 100 patients, 36 of whom experienced disease progression, while 64 did not. And as you can see here on this graph, 37% of our patients presented with thrombocytosis, 25% of them had increased levels of leukocytes, and 25% of them had lymphopenia. And here I'm presenting a wide range of different results in our patient, and you can see that quite a large group of our patients had thrombocytosis, which is marked here by a red arrow. And here you can observe as well a group of patients with granulocytosis. For our analysis, we used two different programming languages. One of them is R and the second is Python. And we also use 4 different statistical methods. First one is Kaplan-Meier model for disease-free survival. Second is Human-Whitney test for analyzing of different FIGO stages. Third, Cox regression univariate model for disease recurrence hazard ratio. And for the same analysis, we use Cox regression multivariate model as well. And now I'll get through all of these 4 statistical methods. So let's start with Kaplan-Meier model for disease-free survival. And we started by assessing how platelets affect the survival probability. You can see the graph on the left side. And abnormal platelets correlates with the lower survival probability compared to the normal range of platelets. And we also confirmed this analysis using another method called log-rank analysis. And you can see that the p-value is 0.002, which is lower than 0.05, meaning that the difference is statistically important. Next, we move to the assessment of how lymphocytes affect the survival probability. As you can see, there is almost no difference in the different numbers of lymphocytes and the survival probability. And the second analysis, log-rank analysis, also confirmed that the p-value in this case is 0.5, meaning no statistical difference. And further, we test how granulocyte counts affect the survival probability. And on the graph on the left side, you can see that there is a difference between red color, which is high granulocytes, and the green, which is normal granulocytes. And the second analysis, the log-rank analysis, showed a p-value of exactly 0.05. So at this point, this result is statistically important, but the lesson for us is to potentially increase the group of patients in the future. And now I'd like to move to Human-Whitney test for analysis of different FIGO stages. And we all know that FIGO staging correlates with worse prognosis, but we wanted to check if our study group also fits these results. And we tested 2 FIGO groups in terms of the total platelet count. And we found that the patients with more advanced disease, meaning FIGO stage 3 or 4, had a higher platelets. Now we move to the Cox univariate model to test disease recurrence hazard ratios. And here, in this model, the result is statistically important when the coefficient, you can see it's marked in the green box, is positive. And the p-value, which I will show you on the next slide, is less than 0.05. And on the slide, we can see that only for platelets, the coef is positive, although the p-value is less than 0.05 in two groups, platelets and granulocytes. And again, the lymphocytes do not correlate with prognosis. And we also confirmed the results above using a likelihood ratio test, which show a p-value less than 0.05, meaning that this model, Cox univariate model, showed results which are correct and true. And our last model, Cox multivariate model, again, I will start with the platelets, and we can see that the coef for platelets is positive. So it means that the platelets have a positive effect on the hazard rate, meaning that the higher platelet count are associated with a higher risk of recurrence. Lymphocytes, again, proved to not have effect on the recurrence and the overall survival probability. And at this time, we also tested how age affects the survival probability. And although we got the results that age has a positive effect on the hazard ratio, meaning that the older patients have a higher risk of recurrence, but this effect is not statistically significant. And as a conclusion, collectively, we can tell that the high number of platelets in ovarian cancer patient is associated with shorter progression-free survival time. Granulocytes have mixed results from test to test, but for sure the number of lymphocytes is not related to the progression-free survival. And here you can see our references. And at the end, I'd like to mark that it's essential to note that our study is only an initial step in understanding these relationships, and further research with larger and more diverse patient population is necessary to validate our findings. But we hope to contribute to develop more effective diagnostic and monitoring tools for ovarian cancer patients. So thank you very much, and I welcome any questions or comment.
Thank you very much, and we have some questions to you.
Thank you very much for the nice presentation. It was really nice to hear that there are some studies on recurrence of ovarian cancer. So the platelets, there were a couple of studies before this study, and they showed definitely the higher platelets rate, the lower prognosis are. So the rate of recurrence is high if you have high platelets. So that's not new. The lymphocyte might be some kind of other point to calculate the risk of recurrence. But my question is, do you know what's the best prognostic actually there are two. The best prognostic marker of recurrence in ovarian cancer, well known, the best two.
You mean the best that there is no progression, or the best that there is for sure there will be progression? I don't understand the question.
Okay, so CA1 to 5, that's one of the marker.
Yeah, and HE4.
Yes, but those are the blood markers. What are the other prognostic factors that will tell you for sure how long the patient will live? There's one, the strongest one ever. Metastatic disease for sure, and invasion of a omentum probably. Operation, if it's cytoreductive 0 or 1.
Yeah, of course. Yeah,
it's the most known prognostic factors, and whenever you calculate the risk, you could always
cytoreduction.
as a co-founder or other factors. So the analysis is very, very nice, but my advice would be to be very careful, because we know that the better you operate, the better prognosis the patient have. If you operate good, you have 5 to 10 years. If you are not a well-trained operator, the lady has only 1 or 2 years and she will recur definitely.
Yeah, but I think that we can also, if we're aware that we have a higher platelets at the time of when we diagnose our patient, we know that we need to put much effort when we operate. Of course, we need to put an effort during every operation, but these patients we should take care of the most.
Powiedzcie mi tylko, czy mnie słychać i czy mnie widać.
Widać i słychać?
Super, dziękuję. Okay, so again, it's time to 8th presentation. Drugi dobrodziejut. Do you hear me?
Good morning. Do you hear me?
Yes, I hear you and I see you. You have your presentation?
Yes, 1 minute. Can you see my screen?
Yes, we can see. You can start.
Okay, so I'm Rugilė Dobrodziejutė, 6th-year medical student from Lithuanian University of Health Sciences. And today I will present a thesis about the effects of physical activity on women's well-being during the pregnancy and delivery. This work's tutor is Associate Professor Laura Malakauskienė. As daily life becomes more sedentary, there is a lot of attention to physical activity. It is important to know that physical exercise has a direct impact on women's well-being, comfort, and physiological adaptation during pregnancy and delivery. It is recommended for pregnant women to exercise at least 3 times per week from 30 to 60 minutes. And of course, to walk outside for about an hour. This work's aim is to evaluate the possible influence of physical exercise before conception and during pregnancy on women's subjective well-being during pregnancy and delivery. Materials and methods. An original questionnaire about sports experience before and during pregnancy was created. The questionnaire was distributed to women after delivery in the Clinic of Obstetrics and Gynecology in Kaunas clinics in Lithuania. All in all, 108 women participated in this study. For data comparison, women were divided into 2 groups according to physical activity experience, active and inactive during pregnancy and before pregnancy. Research data were systematized using Excel program. Data analysis was performed using IBM SPSS 27. The permission of the Bioethics Center was granted. Results. As you can see in this diagram, before pregnancy, more than half of the examined women, that's 57.4%, did not do sports. 40% of women were physically active and 1.9% did sports professionally. Speaking of the types of exercise before pregnancy, while exercising unprofessionally, the most common types were individual exercising, going to a gym, and running. Reasons for not engaging in physical exercise were illness, work, taking care of children, and 50% of women were not interested in exercise. During pregnancy, more than half of the examined women, also 58.3%, did not exercise regularly, and 41.7% exercised. Speaking of type of exercise during pregnancy, the most common ones were aerobics, yoga, stretching, body weight exercises. A large proportion of women, 82.2%, who were physically active during pregnancy rated their state of well-being during pregnancy as good or better in comparison to women who did not exercise, and that was 58.7%. 42.2% of physically active women while pregnant evaluated their state of well-being during pregnancy as great, in comparison to only 20% of women who were physically inactive while pregnant. Furthermore, 9.5% of women who were physically inactive while pregnant evaluated their state of well-being during pregnancy as poor, in comparison to only 2.2% of women who were physically active. Speaking of exercising during pregnancy and its effect to delivery, half of the men, 55.5%, who were physically inactive during pregnancy evaluated their state of well-being during delivery just as average and below in comparison to physically active women. That was 35.5%. 24.4% of women who were physically active while pregnant evaluated their state of well-being during delivery as great in comparison to only 7.9% of women who were physically inactive. So to conclude, physical activity during pregnancy significantly improves women's subjective well-being during pregnancy and delivery, though about a half of participants were not physically active neither before nor during pregnancy. So thank you all for your attention, and I will be waiting for your questions.
Congratulations, and of course it's that we have some questions for you. So
thank you very much for excellent presentation. I have a question. What can be done to encourage women, being that they are pregnant or before pregnancy, to be more active before and during pregnancy?
I think that the most important thing is to give women a lot of information about its benefits. Also, we can mention it during women's visit to OB/GYN, also through internet and other sources. So information would be the most beneficial, I think.
How does it look like in Lithuania? Do you have birth classes that you encourage all parents to be more active?
During classes, yes, we do, but not a lot of women come to those classes, so that's a problem, I guess.
Do you know the percentage in your country of women that are attending the birth classes?
I'm sorry, I could not say that.
Do you know the percentage of women that are pregnant and that are attending the birth classes in Lithuania?
I don't know exact percentage, but that should be about 50%, I guess.
50 or 15? 50.
50, half. About.
Okay. Because no, in Poland it's like less than 20%. Like 15,
oh, wow.
15, not 50.
Yes.
Thank you very much.
Thank you all.
Okay, so thank you very much. Okay, it's time to ninth presentation. Please welcome Wiktoria Laskowska and Angelika Burzy. They will present the paper about knowledge of fertility recovery after pregnancy among women in Poland.
Good morning, everyone, dear committee and other participants. My name is Wiktoria Laskowska, and I am incredibly pleased to present to you the results of our team study from the gynecology and obstetrics field. Our work's topic is knowledge of fertility recovery after pregnancy among women in Poland. After introducing our topic, I will move on to describing materials and methods we used. Then I will present the results and finish my presentation with conclusions and discussion. Nowadays, there are numerous methods of birth control, but the one which especially interested us is lactational amenorrhea method. LAM is a method of contraception based on hormones released during breastfeeding. High levels of prolactin are responsible for producing milk and blocking ovulation to prevent mothers from conceiving again. It has many noticeable benefits. It's free, accessible, and works right away. However, just breastfeeding is not enough to stop the menstrual cycle because there are some strict rules that must be obeyed. Breastfeeding schedules should be very tight, and skipping even one feeding can lead to effectiveness loss. Feedings can be replaced with fluids other than breast milk. It should be the baby's main nutrition. LAM is valid unless a postpartum woman gets her first menstruation after delivery, and the baby should be 6 months old or younger for LAM to work. That's why LAM has a high typical use failure rate. Breastfeeding can be a challenge itself, not to mention trying to keep up with feeding's time and not using any formula. Lack of proper knowledge of LAM usage and return of fertility in general can result in women getting pregnant shortly after giving birth. It's crucial to remember that even while breastfeeding and before the return of menstruation, women are able to conceive again, and that's why we decided to evaluate their knowledge. The aim of our study was assessing pregnant and postpartum women's knowledge of the return of fertility and recognize the sources of women's knowledge on this topic. The survey was performed between March and April 2023 among Polish women by internet. The inclusion criteria for the study were being pregnant or having given birth in the past and being over 18 years old. The questionnaire consisted of original questions and a standardized questionnaire Rosenberg self-esteem scale. Statistical analyses were performed using the statistical software. There were 34 questions concerning their metrics, knowledge of postpartum, fertility recovery after pregnancy, and breastfeeding as a postpartum contraceptive method. Overall, women's general knowledge was appropriate. 91.7% stated that breastfeeding women can get pregnant, and there were no significant differences between various groups. Also, 86.2% of women agreed that the breastfeeding woman should use contraception if she doesn't want to get pregnant again. However, 42.2% declared that breastfeeding doesn't cease ovulation, which shows no particular understanding on the topic. Less than a third claimed that breastfeeding stops ovulation only if proper conditions are present. There was no significant correlation between the age of surveyed women and their knowledge on a given topic. The majority of our respondents were 26 to 35 years old. What's even more surprising, there were no statistically significant differences between primiparous and pluriparous women when it came to the level of correct answers. Also, there was no association between knowledge and Rosenberg SAS questionnaire responses. Nonetheless, there was a notable trend when it came to the level of education. Women with higher education were responding more correctly to our questions regarding fertility recovery and return to sexual intercourse. They contributed for 69.7% of our study group, and 84.2% of these women stated that return to sexual activity is possible no earlier than 6 weeks after giving birth. Additionally, there is strong evidence that women who took antenatal classes were more oriented in our questions evaluated their knowledge. It shows how helpful and valuable the birthing classes are. As I said before, in general, 31.2% of women claimed that breastfeeding stops ovulation only if proper conditions are present, but among women who took antenatal classes, 60.6% of them responded correctly. Likewise, classes proposed by a midwife or academic educator contribute to longer intervals between successive pregnancies, which allows the body to recover, both physically and mentally, as well as maintain a healthy pregnancy. Unfortunately, there were only 30.3% of women who attended classes with midwives, and a very few moms had a proper conversation about the return of ovulation with their doctor. To conclude, surprisingly, there was no correlation between number of previous pregnancies or pregnant women's age with their awareness. Birthing classes, as well as higher education, both contribute to wider knowledge. There is strong evidence that the cooperation between pregnant women and midwives should be strengthened. The results of our study show that birthing classes are very valuable, and that's why we assume they should be promoted among pregnant women. I would like to finish my conclusion with a polite appeal to the dearest audience. We profoundly invite you to start conversations about the return of fertility and breastfeeding as a contraception method with your pregnant and postpartum patients. And that is our take-home message, because our common goal is taking care of women's health. I sincerely appreciate your attention today. Here is a list of websites and articles which we used during preparing our study and presentation. And if there are any questions, I'd be happy to open up a discussion, and I invite my co-author Angelica to participate with me. Thank you.
Thank you very much. Very nice presentation. Slow down next time, please. You were talking very fast. But I know the stress and other things, but it's sometimes, you know, it's better to slow down a little bit, and then everybody can hear and understand you. They were very nice job and very nice presentation and work. 31% says that ovulation can occur during the, only 31% said that it might occur during the breastfeeding. Do you know the Pearl index for breastfeeding?
Yes, if lamb is used correctly, it's effective in as much as 98%. Only 2 women out of 100 would conceive if lamb was used correctly. But as I said, there are many factors influencing that ceasing of ovulation, so it's very hard to be used perfectly.
So would you consider recommending lamb method in Poland and in European countries?
I definitely consider lamb method for women who may have some difficulties with accessibility to other methods of contraception. But while we were researching, we came into other studies. None of them was conducted in Poland, but there were studies prepared in other European countries. And yes, they showed that awareness and acceptance by women is great. And I would advise using this method if a woman has the ability, right? She can breastfeed her baby on demand. She has.
So would you consider using it alone or with combination with other methods?
If it's used perfectly, it can be used up to 6 months because then baby also starts to eat different things, drink different fluids than breast milk. And after 6 months, after delivery, there is a higher possibility that ovulation can occur before the return of menstruation. And the return of menstruation is another very important factor for lamb to be used correctly. So it's only up to 6 months. I wouldn't risk using it past these 6 months.
I would just like to add that we didn't put the Pearl index in the presentation because there were different sources and we couldn't just find the right answer that suits our presentation that we consider as the proper answer. So we just wanted to take into account the different factors and present it to you, and maybe you can then research it on your own with the knowledge that we have provided.
There was a really nice conclusion at the end that the doctors, gynae obstetrician, should consult their patient after there's a scheduled visit after up to 6 weeks after the delivery. So that's the time to consult and talk about contraceptive methods. And usually WHO recommends to combine lamb method with condoms because it's not very efficient in developed countries. In developing countries, that's the only way to not have the baby after 2 months or 3 months after the delivery. So really nice job. Thank you.
We are just hoping that thanks to our survey, maybe some women that have answered the survey, they may have an idea that it is a topic actually. So maybe they can read about it something. Yeah.
And also we've had a few I don't know responses for every questions regarding their knowledge. So maybe they already had some second thoughts after fulfilling our survey. Yeah. Once again, thank you very much.
Thank you.
Congratulations for our participants. And now it's time for 10th work, 10th presentation. I invite Aleksandra Kątnik. No. Aneta. Okay, I invite Aneta Wojtas to present the paper Awareness of Polish Women of Vaginal and Urinary Tract Infections and Their Complications. Stage is yours.
Thank you. Okay, good morning, ladies and gentlemen. My name is Aneta Wojtas, and today I'm pleased to share our team's research result. Our study aimed to assess the awareness of women in Poland regarding intimate infections and urinary tract infections, UTI, as well as to investigate the effectiveness of education by gynecologists in clinics and through social media on improving treatment outcomes. Intimate infections and UTI are significant public health concerns caused by various pathogens, most commonly by Escherichia coli. Their high recurrence rates and increasing antimicrobial resistance pose economic burdens and can impact fertility. Bacterial vaginosis has also been linked to early pregnancy loss. Vaginal infections are a common cause for women to seek gynecological care. Symptoms reported by patients include discharge, burning, itching, pain, discomfort, and redness. Screening for sexually transmitted diseases is recommended for women with suggestive symptoms. Our study focused on evaluating the awareness of women in Poland regarding intimate infections and UTI, as well as on assessing the impact of pelvic floor symptoms on occurrence of infections. We also compared the impact of education from gynecologists in clinics and through social media on women's knowledge. The study was conducted in 2023 using an online questionnaire distributed through an anonymous Google form. A total of 79 women participated, excluding those under 18 years old. Our questionnaire consisted of 23 questions covering group characteristics, information about infections, contraception, sources of knowledge, medical attention-seeking behavior, self-treatment practices, and the impact of education on treatment effectiveness. Additionally, the pelvic floor impact questionnaire short for 7 was included. The PFIQ-7 assesses the impact of bladder, bowel, and vaginal symptoms on daily activities, interpersonal relationships, and emotions over the past 3 months. The scores range from 0 to 300, with lower scores indicating a lesser impact on quality of life. Statistical analyses were performed using a Statistica 13.3 software. Among the participants, the majority, 70%, were in the age group of 18 to 25 years old. Most of the respondents, 61%, had higher education and 27% were in college. 16% were associated with medical professions, while 84% were not. Although vaginal infections occurred frequently, mostly once a year or more often, most of the respondents admitted to self-treating with over-the-counter medications without consulting a doctor during an ongoing infection. A considerable proportion, 29%, never visited a family doctor during an ongoing infection, and 30% only sought sporadic appointments. Regarding the correlation between past infections and fertility, 36% believed there was no relationship. Furthermore, 66% revealed they were not vaccinated against HPV, suggesting insufficient information. However, as many as 87% expressed willingness to receive the HPV vaccine if recommended by a doctor or medical platform on social media. Respondents' knowledge was categorized as low, average, or high, based on scores ranging from 0 to 22. Analyzing the correlation between knowledge level and infection frequency among women in non-medical professions, we found a significant impact, which highlights the importance of education in prevention and need for promotion among Polish women. The frequency of using self-purchasing medication among women in non-medical profession was also significantly related to PFIQ-7 scores. Additionally, we found a statistically significant correlation between PFIQ-7 scores and frequency of consulting a doctor during an ongoing infection among women in medical professions. In our study, knowledge sources were classified as professional, such as medical consultations, books, and social media profiles of medical professionals, and non-professionals, such as acquaintances and medication advertisements. We were unable to prove a statistically significant correlation between respondents' knowledge and the sources from which it originates. However, it is important to note that investigation this correlation would necessitate further research involving larger group of Polish women. In conclusion, knowledge about intimate infections and urinary tract infections in Poland still requires an improvement given their prevalence and potential long-term consequences. Insufficient education contributes to the problem, and addressing it can help minimize complications. Therefore, there is a need for comprehensive education on prevention, diagnosis, and treatment of intimate infections and UTI, to raise awareness and to mitigate the negative impact associated with these diseases. Gynecologists play a crucial role in providing this education. Thank you for your attention. If you have any questions, don't hesitate to ask.
Okay, congratulations. I have some questions.
Thank you very much. Very nice presentation. And I observed that more than 50% of women in this study, but it's a small group though, 80 participants, said that they have never, that they did not consult the infection with the professionals. That's this slide. So, and they use over-the-counter drugs. What do you think? Why it's so high, the number of women that don't consultate, that make any consultation with the specialist when they have infection?
In my opinion, as we have seen from the surveys, as we talk to people, because we encounter different patients throughout our studies, so we can see the hesitance when it comes to the contact with the specialists. Unfortunately, there are a lot of misunderstanding on the internet when it comes to the medical stuff, especially after the pandemic, as we know. So I think people are skeptical. They do not always trust us, and it's very often due to the, as I have mentioned, misunderstanding on the internet. So they would rather they would rather give themselves some medication and avoid the doctor as much as they can. So I think this is the problem. Then maybe such surveys that they make, that we send them, maybe they can resolve the problem because they have higher awareness of the topic, and hopefully it will change in the future.
So 80 participants, but were they all during because they are medical students, or I didn't understand that?
No, this is just a group of women in Poland. So we didn't have any inclusion criterion of the studies, or
they had some medical education. If I
some of them.
Correctly, some of them had medical education. Okay.
Yeah.
How did you approach the group? Did you send it via email or web page, Facebook?
So we have chosen the easiest, but yet the most effective way, of course, which is the online surveys that we have sent via the social media, because this is the easiest way to approach the people that want to actually fill the survey out. So we have chosen this way, which was the most effective for us, because we were able to draw some conclusions and calculate the numbers that we need to draw the conclusions.
Okay, two last questions, I promise. One is the pelvic floor impact questionnaire. Why did you use that? Because I didn't have any result with that. Because you used the questionnaire, pelvic floor impact questionnaire. Mm-hmm. Where did you put it in the statistical analysis? For what reason? Oh, this one. Okay.
Yes, the PFIQ-7 scores were correlated with frequency of consulting a doctor during an ongoing infection, but in the group of respondents of medical professions, and also it was correlated with frequency of using self-purchasing medications among women in non-medical professions.
Okay, and the last question, would you consider the option to call gynae obstetrician and just based on the symptom to get the prescription for the drug for the infection as efficient in Poland? So instead of going to the doctor physically, you can call, talk about your symptoms, and they will give you prescription for drugs, not over the counter, but like normally antibiotics. Mm-hmm. What do you think? It might be efficient and change the number of women that are consulting that with the doctors or are treated in a proper way?
We think that the prescription is just half of the success. As we know, as we have just mentioned, the conversation is the most important. Our main concern is the patients, So the conversation is of the highest importance. We cannot assume that the people know everything medical connected, because mostly those people don't have the medical education, and we have, and this is part of our job to explain many things to them. So this is the hub of the success, both, of course, the prescription, because we need to treat them, as well as explain everything, so that this is better for the future. As we know, as we desire nowadays, the peace and peace of mind. So higher awareness means more peace, better mental health, better education for the future. Mm-hmm. Yeah. Mm-hmm. Mm-hmm. But it won't
I'm
have...
sorry, I need to stop your discussion
Okay.
because time is up. So give a chance to other participants, but thank you very much and congratulations for your work.
Thank you.
Okay, and now please Jakub Kuleta will present for us the paper about impact of hysterectomy on pelvic floor function.
Good morning, esteemed committee. Good morning, everyone. Today, I would like to present to you the work that Ms. Malinowska and I have been working on for the past year. The study effects of hysterectomy on pelvic floor muscles aim to determine the conditions of this muscle by examining the symptoms resulting from their dysfunction, and the results were quite surprising. Before we discuss the findings, I would like to say a few words about hysterectomy itself. As we all know, it's a procedure that involves removing the uterus, and if the procedure is performed radically, usually for oncological reasons, the ovaries, fallopian tubes, and local lymph nodes are also removed. However, the causes of hysterectomy are usually non-oncological. As shown on the slide, the most common reason for this procedure are leiomyomas, followed by abnormal uterine bleeding and endometriosis. This procedure can be performed basically in 3 ways. With laparoscopic and laparotomy via abdominal hysterectomy via laparotomy being the 2 most commonly used methods, but there are some facilities where the vaginal hysterectomy is still the method of choice. According to Sarminis et al.'s research, the method is better than classical ones in terms of postoperative complications. There are many risk factors that have been shown to have a negative effect on functional efficiency of pelvic floor muscles. This includes repeated heavy lifting, vaginal deliveries, high BMI, but also advanced age or even repeated constipations. And it is worth noting that every woman has about 11 to 20% chance of idiopathic pelvic organ prolapse, making it even more important to avoid additional risk factors. There are several main symptoms of pelvic floor muscle dysfunction. The most important ones asked about in a questionnaire we used are urinary and fecal incontinence, pelvic organ prolapse, stress urinary incontinence, and overactive bladder. The aim of the study was to determine the effect of hysterectomy on the pelvic floor muscle function. And to determine this, we gave the EPIC questionnaire, which stands for Epidemiology of Prolapse and Incontinence Questionnaire, to 81 patients from the National Institute of Oncology in Krakow. 51 patients of this group who underwent hysterectomy constituted the study group, while the remaining 30 patients were the control group. The EPIC questionnaire was created by Professor Emily Lukács from University of California for screening diagnosis of pelvic floor disorder in women, and the sensitivity of the questionnaires was shown to be an average 88%, while the specificity was an average 87%, which is a very good result considering that such a questionnaire can be given to any woman in a clinic without incurring any additional cost. And this slide shows the characteristics of the study and control group. It is worth noting that most women in both groups gave birth to children, and most deliveries were vaginal. The BMI, which indicates the presence of another risk factor for pelvic floor muscle dysfunction, it is overweight, also should be noted. And based on questionnaires given to the patient and diagnostic key prepared by authors, we're able to diagnose three main alignments in the patients, which is overactive bladder, fecal incontinence, and stress urinary incontinence. And at this point, things got interesting because 20% of women in a control group suffered from overactive bladder, while only 6.7% of the of the study group did. The fecal incontinence was almost equally common in the study and the control group, but 10% more of the patients in a control group were diagnosed with stress urinary incontinence. These results are quite interesting because many authors cite hysterectomy as a risk factor for pelvic floor muscle dysfunction, so we expected quite different results. And I would also like to add that none of the patients were diagnosed with pelvic organ prolapse. Here we have a comparison of average coefficient values in individual group of patients from the control group. The fact that the values of almost all coefficients are exceptionally high in a group of patients diagnosed with depression draws attention. And this is another interesting relationship that the questionnaire pick up on and has been discussed in other scientific papers. It turns out that the symptoms of urinary and fecal incontinence strongly predispose to alienation and then depression. This relationship is also visible in a study group, but it should be noted that in other patients group, the coefficients are significantly lower than in a control group. In summarizing this work, I must admit that when we began our research, we assumed that the results would be exactly the opposite. However, we have found that hysterectomy performed by trained specialists using the appropriate surgical techniques can have positive impact on symptoms resulting from pelvic floor muscle dysfunction. Additionally, this work confirms the findings of other researchers regarding the predisposing influence of symptoms such as urinary incontinence on occurrence of depression. And the research also shows that hysterectomy has the least positive impact on symptoms related to fecal incontinence. Thank you very much to all of you for your attention. Here is the bibliography. And if you have any question, I will be more than happy to answer them.
Congratulations.
Thank you very much. Very nice presentation. But can I see the age, the mean age of the population? Because the results are quite interesting and surprising. No, just the age of the groups.
The age, yes.
The mean age, 50 and 57, that's similar. Because like, we don't have any papers showing that hysterectomy can have a positive impact on overactive bladder, anal incontinence, or stress urinary incontinence. Mm-hmm. Sometimes we have some studies saying that it's opposite, so it increases the rate of stress urinary incontinence. Anyway, my question is, what were the indications for hysterectomy? That might be the point. And the other question is why the anal incontinence rate is so high. It's 20% of the control group. That's really high.
Mm-hmm. So the hysterectomies in this group of patients was performed mostly from oncological reasons, because it's they were the patients from National Institute of Oncology, and except of the hysterectomy procedure, the patients was treated also with chemo and radiotherapy. So this is maybe why the fecal incontinence rate was so high in this group of patients. The control group, of course, didn't underwent the hysterectomy, and the most of this group also didn't underwent chemo and radiotherapy. But we believe that the results may be accumulation of several factors, and one of them may be the techniques that surgeons from this institute use, because as we know, during the operation, they almost always use the colposuspension on the round ligament of uterine. So the walls of vaginal walls are most of the time more tense compared to the times before the surgery.
But from the physiological point of view, it cannot have any influence of urinary incontinence on overactive bladder, because the mechanism of that disease are completely different. So my point is that when you interpret the result and you have only 50 cases in the study group and 30 cases in control, you have extremely high percentage of frequency of anal incontinence in controls, because it's 20%. You should be very, very careful. And the other thing is that the paper on that, the study group, it's oncological patient, so you cannot interpret that study and just go with the results to all of the women that are undergoing hysterectomy.
Yes, of course, we are very aware that we cannot from now on say that every woman should be treated with hysterectomy. We think that the further research is very required, so we can confirm this hypothesis. Thank you very much.
Thank you very much. Okay, and now just 2 presentations left in our gynecology and obstetric session. So for 20th paper, I invite Patrycja Cieślikowska to present the paper about the pharmacological induction of labor with dinoproston. Oh, okay, I'm sorry. So I invite another author, Monika Chlipała.
Yes. Good morning. My name is Monika Chlipała, and I'm pleased to present to you, on behalf of myself and the co-author of the work, Patrycja Cieślikowska, a presentation on pharmacological induction of labor with dinoproston, factors influencing a complete induction of labor. I will start my presentation with the table of contents. At the beginning, a few words of introduction. Then I will present material and methods used in the work. Then results. And finally, I will introduce you the conclusions that came up from our work. So at the beginning, I would like to answer the following questions. What is dinoproston? What is the function of dinoproston? And what is the aim of our study? And dinoproston is a synthetic analog of prostaglandin E2. Dinoproston increases the strength and rhythm of contractions and dilates the cervical os, which is relevant for the labor induction. Dinoproston is not only used in labor induction, which means the termination of pregnancy, but it is also used in bleeding after delivery or in newborn babies to keep the arterial duct open. The aim of our study was to evaluate factors that affect the effectiveness of labor induction without the need for performing any additional support like oxytocin or Foley catheter. Now I will move to the material and methods. Our research group consisted of 151 women in the age of 22 to 41. The data was collected based by analysis of the patient's history cards in the hospital University Clinical Center named by Professor Gibinski in Katowice, and it was collected from the January 2021 to March 2022. The factors that we have taken into account were gestational age, presence of comorbidities, cervix score, and another medical reasons for labor induction. Our study was a retrospective study based on history of patient records, and we analyzed it with Statistica software. The criteria for inclusions were patients referred for plant induction, dinopreston dosage using the Cervidil medication as a necessary requirement for each patient, age from 18 to 45 years, and finally, of course, patient's consent for plant induction. As you can see in the slide, we've got the dosing schedule of dinopreston. There are a few methods of labor induction. We have got cervical gel, we have got vaginal tablets, vaginal pessary, and also a vaginal gel for primipara, a woman who is giving birth for the first time. And the ranging doses are from 1.5 milligrams to 10 milligrams every 24 hours. Regarding the results, we found out that the most common indications for labor inductions were, firstly, gestational diabetes mellitus in the number of 36.4%, then extended time of delivery in the number of 34.4%, and then pregnancy-induced hypertension in the number of 11.43%. And you can see in the graph, the graph is divided into 4 sections, every section for each indication, and the 4th section is for other indications. And natural labor occurred in 96 patients. The group of only Cervidil induction consists of 93 women, in which there were 62 natural births, but this was not statistically significant for the rate of labor induction. Foley catheter as an additional support for the induction of labor was presented in 58 patients, in which natural labor occurred in 33 patients, but this was not statistically significant. Additional oxytocin did not have an influence on the rate of labor induction. Slow-release dinopreston insert is safe and effective method of labor induction in low-risk pregnancies. And moving on to the conclusions, we found out that Cervidil is an effective method of labor induction, and the effectiveness of pre-induction is associated with the initial preparation of the cervix determined by the Bishop score. And the higher the Bishop score, the more effective is the labor induction. Low Bishop score, which is synonymous with unprepared cervix, is a high risk for a cesarean section, and dinopreston induction of labor is safe and effective method for labor induction in cases of low Bishop score. This is the bibliography we relied on during our study, and thank you very much for your attention. Now I would like to move on to the discussion.
Okay. Now it's time to 3 minutes of discuss, so please.
Very nice work, and the subject that we are talking about, it's quite important, as we have an increase of indication for labor induction or pre-induction. So my question is, which method of pre-induction of labor is better? Foley catheter or dinoprostol vaginally? What do you think? More efficient.
In our point of view, maybe dinoproston. We also find some articles in which were information about that it's safe. About
it's effective in
yes, and about Foley catheter, we didn't find something like this. So, in our point of view, maybe dinoproston is a better option for pre-induction.
Do you know other methods of pre-induction? Because you can the route of administration of drugs, because you said it's vaginally, and you can use the Foley catheter. Do you know any other options for the ladies?
You can use oxytocin as well, but you can
it's
have
like
the time
induction.
interval.
Oxytocin, you usually, it's not recommended to use oxytocin in pre-induction, just induction, because you have to distinguish pre-induction when you are preparing the cervix. As you said, that's very fantastic, because everybody has to notice the difference. When I was a student and resident, I didn't know the difference. Now I know, because the different times anyway. And there is a new drug called Angusta, and you can give it orally. So now that we have a trials checking if it works as well. But very nice work, very nice study comparing different methods and showing that it's effective. There has to be some indications for that, and the bishop's call has to be implemented when you are trying to pre-induction. And I'm really glad that you said that, and that was in the slides, that you need to calculate the bishop index before you start pre-induction. Thank you.
Maybe other participants have questions? No questions. Okay, so thank you very much again. And now it's time to the last participant today. That will be Urszula Guzik with work about knowledge and attitudes of Polish society towards in vitro fertilization as method of infertility treatment.
Good morning, every arrivals, dear professors and students. My name is Urszula Guzik, and I'm a representative of student circle in Department of Nursing and Gynecology and Obstetrics and Department of Women's Health in our Medical University of Silesia in Katowice. Our paper has a topic knowledge and attitudes of Polish society towards in vitro fertilization as a method of infertility treatment. Okay, so let's start with the background. The natural and integral part of human life is a procreation. Around 10 to 15% of couples experiences difficulties with conceiving a child. That problem require an interdisciplinary cooperation with gynecology and obstetric specialists who plays the main role. We have to use laboratory techniques, genetic engineering, and direct work with human gametes and embryos. So, Polish society is diverse. Taking any decision related to IVF cannot be based on only on clinical and economic premises, but also the moral aspects too. Difference in the society. results from age, educational level, and professional activity, also religious. Due to the globalization, European and global influences are also present in our society. The aim of the paper is assessment of knowledge and attitudes of different social and religious groups toward in vitro fertilization. The materials and the methods. So we conducted a questionnaire in a group of 341 women and men in the middle age 36. We made a survey with 32 questions. They were open and closed. We made that survey via Facebook and also in traditional way. The research was conducted from February to April this year. Yeah, and the results. The average age of male and female participants was 36. 54% had received higher education. It's a very important thing. The vast majority of the subject describes themselves as believers. Half of the respondents have children, and also almost half of them declared the willingness to have offspring. Among participants, 6% declare having been or being treated for infertility. Take a look at those figures. As can be seen from, most participants have complete level of knowledge independent of age. The figures reveal that majority of women and men accept IVF independent on educational level. The data would seem to suggest that the profession do not affect on opinion, but in a group with another than medical profession, we see that it's the biggest group with which have an opinion about IVF. Next. So several free results were that opinions about IVF according religion, and we see that the group of Catholics who accept IVF is also big, but a non-believer often accepts IVF. Knowledge and attitude of Catholics concern IVF. So that's the Catholics who practicing faith, and that's the 70% of all Catholics. And that group critically looks at the official Catholic Church attitude. They also have knowledge that the Church looks negative at that fertilization method. And they accept, in spite of that fact, IVF. We see that the opinion of Catholics towards IVF it depends of the age. So yes, thank you. Knowledge regarding IVF and Catholics who accepts or do not accept that method. It's interesting that respondents who do not accept IVF are the biggest group with the proportion of any knowledge. We also ask about declaration concerning using IVF method towards people without children and also having children, and we don't see any relationships. The same question we ask people who plan children and who do not plan children. And the most interesting thing is that more people who do not plan children at once concern IVF. Opinions regarding reimbursing the in vitro fertilization, it's very positive because people mostly want that IVF will be reimbursing by the state. Okay, and let's get to the conclusion. So Polish society, regardless of age, sex, education, approves the IVF fertilization. Opinions about the IVF are dependent on the level of knowledge and belonging to a religious group. And the Society of Polish Catholics, to a great extent, is against the opinion of the Catholic Church, denying the IVF method. Yeah, that's our literature. And thank you for your attention, and I'm looking forward for your questions.
Congratulations.
Congrats once again. Very nice presentation, especially the topic and subject of IVF. It's like hot subject every time, every year.
Yeah.
And we have now in Silesia, it will be introduced in a few months, voivodal program for IVF. 200 couples each year will be, 600 couples will be included in that. So that's a very nice program. And about the presentation in the study, what does it mean, complete knowledge?
Okay, so we check that because we ask in an open question for respondents, and they have to write and answer the question, what do you mean as IVF? And our circle group, we research that answers and analyze. So when someone has all information about IVF, we make that as a complete answer. And when somebody take a mistake during that answer, that was a partial knowledge. And when somebody nothing right in that question, we thought that was any knowledge.
So it was interview. Okay. So
yeah.
it was like a test, and you
calculate
the scores.
Because there was also a closed question.
Okay. Okay. What do you think? What are the best strategies to increase the knowledge and the acceptance of IVF in Poland?
I think that we should talking about it, and the most important problem with IVF we've seen in the group of Catholics. So I think that the head of the church should talk with the specialists like gynecologists and obstetricians to speaking about that topic, and looks more for medical aspects of that thing.
And also, nowadays we have to remember that knowledge about in vitro fertilization, the teachers don't give us any knowledge in primary and secondary school.
Yeah, that's also
only one way probably is the internet nowadays.
Mm-hmm. Thank you.
Another question? Yes. Okay.
I would just want to ask if you feel like the acceptance of non-heteronormative couples trying IVF for their childbearing plans should be like that they should be more widely accepted in the medical community when trying to conceive in Poland, because in other countries it's obviously a bit more accepted for queer couples to try in vitro.
Okay, thank you for that question. So you think that that couples have problems in Poland to get that IVF? Yeah, I think that in our environment gynecologist in Silesia, we doesn't have that problem, because we help that couples. We have a lot of clinics and specialists to make that method of fertilization.
Thank you.
Our time is up, so thank you very much. Yes. Okay. And finally, all the submitted papers have been presented. We congratulate all of the presenting authors and participants of the gynecology and obstetrics session. At this point, I would like to ask the president of the jury for a few words.
Okay, thank you very much. You were all excellent. It's a huge stress going there on the stage and presenting the results of your study, especially that you are open for the critics. Some points that might be presented in a different way. But when you sum up all the presentation, the way you did it, the topic you chose for the study was really amazing. And I'm sure that all of you will have a fantastic opportunities to develop your careers. And I wish you all to replace this place in the future. All of you have the big chance because you are fantastic, great knowledge of English, you speak perfectly, and the results and the way you presented were amazing. So congrats for all of you. I hope that everybody of you are happy with what you presented. There are only 3 places, but all of you won this competition. You are the best, and congrats.
Professor, really thank you for those words, and also the doctor, really thank you for your opinion. And now we would like to invite for the decoration and closing ceremony of the SIMC 2023 conference, which will be held in A3 Hall today. So it will be at 4:15 p.m. And I would like to thank you again, all of our participants, and see you maybe in next year. Thank you.